I would like to introduce our first speaker today, who is Jessica Grow. She is the Deputy Director of Vocational Rehabilitation Policy and Resources Division for the California Department of Rehabilitation. And I'm going to stop sharing, see if we can get her on the screen. Jessica?
Thank you, Teresa.
Great. Thanks so much for being here. I'll let you get started.
Okay, thank you. So hi, everybody. Teresa gave you my working title. I work for the Department of Rehabilitation, and our vision at DOR is employment, independence, and equality for people with disabilities. I'm a little nervous because I'm going to talk about myself, not my work. So I'm a person with a substance use disorder. I've had a long history of all sorts of different substances, but the most important one, I guess, that really brought me down to the bottom was my addiction to heroin. And I've been in recovery for a long time now, which is great, but I also experienced major depressive disorder. And it wasn't until those two things came together and I started to treat both of them that I've been able to achieve any type of long-term recovery. So for me, I was what you would consider a functioning addict. I was holding down a job. In fact, at times I was getting promoted at work, but I also was incredibly poor in my quality of work at times, and to include terrible attendance. But then I would also have periods where I was able to thrive. So it was a real difference, Jekyll and Hyde in some ways in my work life. I did seek assistance through therapy and seeing various, going to clinics and getting various help as far as my mental health went, but I didn't know that I had any type of mental health disability. I just thought I was stuck in my life. And of course, I knew that I was also keeping this secret about my drug and alcohol use. And none of those counselors that I saw ever asked me directly anything about my drug or alcohol use. It never came up, and I, of course, didn't bring it up. So I went to treatment for the first time in when I was 28, and stayed sober for a short period of time until I completed that program. And then I didn't try to get sober again until years later, and eventually went to my third treatment center when I was age 35. The difference with the third time that I went to treatment was that the treatment team asked me, did I think that I may be depressed? And I answered honestly, I didn't know if I was depressed because I was a heroin addict, or was I a heroin addict because I was depressed? I didn't know which came first. Was I using because of an underlying condition, or did I have that condition because I was using? And I couldn't tell the difference. So what we decided to do was wait a little while until I had the substances out of my system for longer and then revisit the issue. So several weeks later, maybe even a few months, I can't remember now how long ago, it was, but what period of time it was, the treatment team came back to me and said, we think we're still seeing signs of depression, and we'd like to do some assessments with you. And so I agreed to that. And sure enough, the assessment showed that I had major depressive disorder. And so I started on the journey of taking care of my mental health. And I don't think, in looking back, I don't think that I would have been able to be successful at recovery if I wasn't at the same time learning about how to take care of my mental health. And the practices that support one support the other so beautifully. Not sure what else I want to share with you guys today, except to be a face for someone living in recovery. I represent the department in a executive level position, and it's important to be able to talk about substance use disorder and mental health openly. I haven't always been open about it. I didn't start my work life telling people that I was in recovery. It's something that I've come to embrace in I'd say about the last 5 years now. And it's been incredible every time that I've had the opportunity to talk to people and to talk to especially our department, and share my story, how many people come out of the woodwork to say, me too, or my loved one, my partner, my child. It's all around us. There are people on this call who may be experiencing substance use disorder or have in the past, and it still carries such stigma. So people may not be disclosing that fact, and I can respect that. It wasn't an easy decision for me to make, and it still brings me a little bit of trepidation. But again, it's so important, I think, to carry that message, and it's worked out for me so far. So I'll keep doing it as long as I'm asked. So with that, I'll turn it back over to you, Teresa.
I'm just doing a sound check again. Can you hear me?
Yes.
Yes.
Okay, good. Thank you so much, Jessica. Really appreciate you sharing your story again. And I know last time I asked you to do this, I think there were 115 people that were on the teleconference, and I really appreciate it. I think you're helping us, and California needs to really grow in our understanding. We need to be educated on knowing more about substance use disorder and what works, and that people are able to have wellness. And so really appreciate your story. Thank you.
My pleasure.
All right, we're going to move now to LaShawn Francis, who is the Senior Director of Behavioral Health for Children Now. Thank you so much, LaShawn, for joining us. I'll let you get started.
Great. Thank you so much, Teresa. And thank you, Jessica, for sharing your story with all of us. I really appreciate how we started this meeting and grounding it in lived experience. One of the things that I usually do, which I don't think I have to do with this group, is talk about why we should care about children and youth and addiction. And I think everyone here is convinced, so I don't want to spend too much time doing that. But what I do want to talk about are the conversations that we've been having with youth groups that we've worked with and what we've been seeing in the policy field in response to substance use disorder as it pertains to young people. And so really quickly, one of the reasons, besides the fact that Children Now is an organization that is focused on policy outcomes for children and youth, and I don't know how many folks are familiar with Children Now, but we are a statewide research policy and advocacy organization that focuses on the whole child, children's well-being. I specifically lead our behavioral health portfolio, which for us is mental health, youth addiction, and trauma, so small things. And one of the things that I like to say, or I like to remind people, is that adolescence, that time period in adolescence, is the most likely time in a person's life where they will develop an addiction. So we really should be paying a lot of attention to how our young people are experiencing substances and their relationship to them. One of the things that happened a few years back was the introduction of the statewide Children and Youth Behavioral Health Initiative, which we were all excited about. It was almost $4 billion in funds that was supposed to impact all children under the age of 25, that covered not just mental health, but also youth substance use disorder, and was payer agnostic. And so as an organization that does advocacy work, we called up some of our youth org friends and we said, really exciting time. CYBHI is here. They're going to do stuff in the space of substance use disorder. What would you like to see? Especially because there was a lot of conversation around providing educational services in schools. So we said, what needs to happen in schools? They want to do some education. What should that look like? And the young people said to me, this is great, but we're not that excited about it because right now, if you are caught doing drugs on campus, you will be suspended or expelled. So who are they providing educational services to? The young people who probably need them and need the messaging are likely not there or not there consistently. And that really started a light bulb moment for us because it wasn't an area that we were particularly familiar with. So I started doing some research and they were right. What we found out was there is education code that essentially gives school districts discretion on whether or not they suspend and expel. But that discretion isn't applied evenly when it comes to drug-related reasons, right? So we found out that if you were poor, if you were a boy, if you were Black or Latino, you were disproportionately more likely to be suspended or expelled for drug-related reasons compared to their peers. And this is an important part because what we found out for more wealthy school districts, white school districts, wasn't that young people weren't using drugs, right? Because we know that addiction is irrespective of race, ethnicity, and income. It was that they were finding different ways to handle the problem. And those ways included drug treatment, mental health treatment. It usually did not involve a push out culture. And so our young people said to us, look, the state can spend all the money it wants to in schools for education, and that's great, but no one is comfortable talking about drugs while we have this push out culture in place. So that got us started on this really long, years long journey where we were really trying to move schools towards a more public health approach in connecting students with services as opposed to suspending and expelling them. What we ended up getting was a bill that was signed last year, AB 2711. And what it says, instead of what we originally wanted, was that if young people disclose to an adult on campus that they were having, that they were using, they could not be suspended or expelled. And this essentially had to be negotiated because what we found out and what we kind of already know is that the stigma around drug use is still so high. The most progressive legislative members, the most progressive people were really struggling with this idea of not quote unquote punishing young people for drug use on campus. And so that was a narrative that we really struggled to overcome. We couldn't overcome this narrative that young people needed to be punished. They needed to be suspended, they needed to be expelled. Because what we were trying to let them know is that school connectedness is actually an answer to drug use. The more connected you feel to the school, the more likely you are to interact with an adult who cares, the less likely you are to abuse drugs. It is hard to feel connected to schools if you are not there and if you are forced to not be there. So we thought this was a pretty obvious thing. The research supported it. And we really struggled to get that over the finish line. When we spoke to young people about the final version of the bill, what they said was they still thought it was helpful to have language that said they couldn't be suspended if they disclosed, because part of the reason why they don't talk about the issues that they were having is because they are scared of getting in trouble. So even though we ended up going in a different direction, they thought it was still useful. And we try to make sure that our work is useful to young people as well as parents and caregivers. The other thing that we talked about at length is the truth around drugs. So a lot of times we talk about education, but for those of us like myself who grew up at the height of the DARE program, what the DARE program did essentially was a scared straight approach, right? Like, this is your brain on drugs, et cetera. You know, marijuana is a gateway. That simply doesn't work. What young people were asking for was actually research, evidence-based research on why using marijuana vape pens were not good for them. that is a messaging that we continuously heard, that they simply weren't getting the message about what was so harmful. As a matter of fact, I would even say that with the boom of marijuana shops in California and the conversation around marijuana, what we've been hearing is not just young people, but also parents around this narrative around marijuana being natural and not being as harmful as, say, tobacco, right? So everyone is clear that tobacco is bad. We've seen the rates of tobacco plummet, largely due to the public health response on tobacco and the education that we've given people on tobacco. But since the introduction of vape pens, we've seen an explosion of vape pens being used by young people, right? So many of them would say they don't smoke, even if they use vape, even if they vape. That is an interesting fact. This is especially true once we take into consideration tobacco flavored or flavored vape pens. So you've got companies who are targeting young people using flavored pens to get them hooked and addicted. And most of that stuff is happening online on social media, but vapes are the most common product used by young smokers today. And then the last thing that they talked to me about was simply supporting their mental health, right? So Jessica mentioned how important it was to address both the mental health, right, and the substance use disorder. And young people are very clear that they are self-medicating. They are sad, and that is why they are using. And until we're able to hold that tension, right, that they are drinking, they are smoking because they are also sad, until we're able to recognize that, I think we're going to struggle with this conversation. Now, the good news is that overall drug use is down amongst young people if we're comparing it to, say, the last 20 years. The bad news is with the introduction of substances like fentanyl, drug use has become more deadly. So, and then you add in the social media component of being able to access things online. We saw this explosion during the pandemic of overdose rates by from young people. So there is a tension here of understanding that, yes, we've come a long way. By and large, young people are using drugs less, and using drugs has become more deadly for young people with the introduction of things like fentanyl. And so really trying to figure out how to balance that. So what we've been doing is we've been encouraging the state to do a few things. One, end the policies that encourage push-out culture as opposed to supportive mental health services, treatment for our young people, particularly because what we have seen is wealthier families, white families are getting those services. It is simply what we've been seeing is that those schools that are less resourced, right? And so I'm not saying that they don't necessarily want to provide these support services, but those schools that are less resourced are turning towards suspensions and expulsions the most. The other thing that we've been pushing is fact-based educational programming, ones that aren't riddled with necessarily emotion. And I've seen some good things, but they haven't been scaled. The important thing to remember about the educational piece, what we're finding is it's not enough to just educate the student. We also have to be educating parents, because with the ability for folks to buy marijuana legally now, you've got a lot of parents who are smoking marijuana at home in front of their kids. The conversation of drugs has changed, right? So it's got to be a multi-generational approach. We cannot just talk to young people about drugs. We also have to be talking to their parents. And then lastly, support their mental health and provide those counselors, provide those peer supporters, so that young people have someplace to go when they're feeling stressed, when they've gone through a traumatic event. And we know that the state has struggled to provide mental health services to every child that needs them. So really pushing the state to increase access across income lines. So those are the things that we focused on that I wanted to talk about today, and I'm happy to take any questions at the appropriate time.
Thank you. I'm hearing applause in the room. I'm sure it's happening throughout California. So thank you so much, LaShawn. Appreciate that. Does anybody have a question? We can also wait till the end. And if a question comes up, if you're able to stay on, LaShawn. Okay, let's go next to our speaker from the California Opioid Maintenance Providers. Oh, we do have, you can do it now if you want to. Yeah, we can go ahead with that.
Are you ready for me?
Just a moment. There's a question in the room for LaShawn, and then we'll
Perfect.
go to you. Sorry.
No worries.
Afternoon. Yeah. Good afternoon, LaShawn. This is Dr. Monica Caffey, San Bernardino County, Chair of the Behavioral Health Commission there. I was wondering, with the data that you found, is that posted on your Children's Now website for access to the public?
The data, is this the data regarding the suspensions and expulsions?
Yes.
Oh yeah, so it's actually on CDE's website. It's even better. We got it from them. We didn't have to do much. So I can send that around to Teresa as well so that she can share with the group.
Thank you. And also with some of the outcomes that you found, were schools receptive to changing any of those policies based upon you obviously letting them know what the facts are? Thank you.
Yeah, so I'll say it was a mixed bag. We actually spoke to a number of school districts, and the good news is some school districts said, oh yeah, we know, we're trying to do better. Here's what we've done so far to try to stop this, the push out culture. Other school districts said, we just don't have the resources to connect young people to services. And it's unfair to the other students who might not be struggling if we keep young people who might be using in classrooms or at school. And so one of the things I've always said is, look, these are all valid concerns and restraints. But, if we have a goal of making sure that we don't lose young people to drugs, then we have to come up with a different solution. For us, that solution included the fact that CYBHI had dollars that were specifically earmarked for this issue. And if we're not using those dollars in the appropriate way, then that is a separate conversation.
This is Christine Hatia from Napa County Behavioral Health Board. We recently had a work group that reported on adolescents and cannabis, looking at the levels of use in Napa County and also looking at the health impacts for the adolescent brain. And so one of the things we're struggling with is how do we create or get that educational process going, because we feel like our schools aren't really addressing cannabis. And, we were very alarmed to learn about some of those impacts. And our board is trying to figure out what is it we can do? Where should we be going? How can we have an impact on the community regarding this issue?
Well, at first, I applaud you for doing the research, because I think that research has been hard to come by. And just because of our federal laws in the past about research on marijuana, we've been unable to specifically pinpoint what the harms are. So one, congrats on being able to get that done. Two, you're in Napa. I can't imagine that if you contacted a high school or elementary school, that they wouldn't allow some type of partnership if you were going to volunteer your time to educate young people on these things. I think the educational efforts are going to have to be community-based and localized. So you're already thinking the right way if you want to focus on Napa. While I think the state can provide resources for educational efforts, I do think it'll be best received if organizations like yours go into schools and do the education.
Hi, Stacy Dalgleish, Los Angeles County. Thank you so much. I'm concerned about the surge in charter schools, many of which are backed by, conservative, sometimes religious groups that are, hiding in the background, and what that's going to presumably happen in the future in our country, and how your inroads have been with charter schools in this area.
That's a great question. We have not been looking specifically at charter schools. What we've done is tried to work with the school districts, which would include charters. So we haven't been pinpointing individual schools in that way. And I think every district is just going to have a different story when it comes to charter schools. But I definitely think that your concerns are valid. But we've been working primarily with county offices of education and school districts on these issues.
My name is Denise Coleman from Solano County. As a mother, I am glad that we've started the wellness centers in the schools that have let them be set up. So I think that's working for the kids. But as a parent, I see, I'm coming from trauma from the past, from family members losing their kids for being honest and talking to people. So I can't even imagine someone wanting to really be honest with me about their drug use that has children. So, because it has not been, like you said, kind to people of color, especially when we get caught up in the system and we lose our kids for smoking weed. So, hopefully they have some better support systems and maybe more surveys that go out to people that actually lost their children and get them on a board to what they thought could have been more of a productive outcome for them as a family compared to people who have not been in that situation. And that's something that you don't see much of. So I just hope they have more of that in the future. Thanks.
Completely agree. And it's one of the reasons why you don't hear us talk about, the screening aspect that much when it comes to adults for this reason. We tend to focus more on mass education and trying to educate families, but that is, you're absolutely right. That has always been a concern. And until we fix a combination of our child welfare system as well as our judicial system, I think that will continue to be a concern for families of color.
Hi, my name's Steve McNally from Orange County. It's good to see you, and thank you also, Jessica. I'm always struck by how few people are aware of the Healthy Kids Survey or the connectedness scores that are available for each school, and how you can trend, and that's also available by elected districts and whatnot, so many different areas. And what I was going to ask you, because I gave you a fan club a long time ago, because I'm really impressed with you and Alex Briscoe and all that, that we need to understand who the champions in the state are to be shared with everyone. Because when we go to school districts, they can all order Narcan, they don't do it. They can all do X, Y, and Z suicide, they don't do it. They think it's like if we bring it up, it's going to happen. And when you talk about education campaigns, a lot of times, like that SAMHSA stuff, have the conversation. It may not be perfect or sees the awkward or whatever, but instead of keep creating stuff, why don't we just take all the free stuff and make it easier for the kids, young people, to curate the activities through the clubs that are on campus at one point. So I know everyone here is preaching to the choir, but people really make a difference, and people also stop a lot of stuff from happening when it's all freely available and easy to get to. So keep up the good fight, and thank you very much.
Thank you.
Oh, we have one more in the room. We're almost there.
My name is Cliff Caffey. My question is, we're talking about the education system, and all the parties involved are educators. Why isn't that these programs are integrated into education? Why aren't there classrooms that are designed for the education, since that's what they're there for, to be educators. Even in areas where you talked about in urban areas, for example, they say they don't have the resources, but they're all teachers. So why aren't those teachers that are already there integrating this into their educational programs is what I don't understand.
That is a long conversation. What I will say is I have been doing this work for quite some time now, and the gap between education and health is very, very wide. So we can't assume that simply because they are educators that they understand the health consequences of some of these things. You combine that with the fact that their responsibilities legally don't include health education. And the tests that they take, that they're teaching for, they don't include public health information, right? So I think there's a lot of things about the system that does not encourage the integration of education and health, generally speaking. That is why we don't see a lot of things happening. But I'll be honest with you, I don't know how many educators who are not in this space of public health know a lot about what we're talking about today in terms of the statistics and what works and what doesn't work and how we should be talking about it. And that's not necessarily their fault. That's just not, they majored in history, they majored in math. These are kind of different things that we've been seeing. So I don't take it for granted that we definitely need more cross-sector collaboration between health and education. I also don't put the onus on teachers to be the ones to have this conversation, because I do think this is a unique conversation that if you are not aware and trained to have it, you might not be able to.
Thank you so much. Really appreciate the information, LaShawn, and I'll post any links that you can share with us. Oh, there's one more. Go ahead, Gregory.
Yeah, thanks, LaShawn. I guess what I'm asking is, besides yourself, and I'm quite aware of what Children Now has been up to, besides yourself, are there other statewide organizations who are providing support to local behavioral health boards or other groups about the ideas that we should be pursuing?
Yeah, so the California Alliance of Children and Family Services, they represent community-based organizations that provide mental health and addiction treatment services to young people. They've been a really big supporter in the community of these kinds of things and can definitely support the education here. And they work with providers directly who are going out into the community. So I would definitely raise them. Then you've got Cal ACAP, which are the child psychiatrists essentially, and they form their own association, and they're really interested in going out to the community and providing services and being an educational hub. So those are just the two off the top of my head that I know that I've worked directly with to try to get our state officials to do better. And the benefit of them is that they have providers that actually do go out into the community and try to work with young people. So I hope that answers the question, Gregory.
Yeah, it
And I can get some resources out to the counties too, so that they can bring speakers, to their meetings to help them as they make their recommendations. So I made a note of the two that you just mentioned, but I'm sure there's more. Locally, that's something that you should be asking staff about too, is what organizations should we be talking to? All right, so thanks so much, LaShawn. I appreciate the presentation and answering all those questions. Let's go next to Jennifer Alley. She's the Executive Director of the California Opioid Maintenance Providers, and I'll let you get started.
Hi, good afternoon, everyone. What a great panel so far. I really enjoyed hearing from Jessica, and LaShawn is always just a great resource for information on issues impacting children. So I'm the executive director for the California Opioid Maintenance Provider. We're an organization that represents narcotic treatment programs in California, and they specifically treat people with opioid use disorder. So we've heard about, recovery and preventing, addiction, but I thought it might be good to kind of just level set on what does it mean when somebody is addicted, right? The individual finds it difficult to adjust or eliminate their opioid use in response to problems associated with their misuse of opioids. Individuals who become dependent on opioids often experience intense and severe withdrawal symptoms, strong cravings, which make it difficult to stop use and to participate in their everyday activities. And so NTPs were originally licensed in the for several years. COMP was formed in 1991. And treatment in an OTP, or OTP is what they're called at the federal level, utilizes a multidisciplinary team that includes a physician, nursing staff, licensed behavioral health providers, certified substance use counselors, and peer support specialists. And this approach allows the NTP to stabilize the withdrawal symptoms and engage the individual or their patient in addressing their behavioral needs related to their opioid use disorder. So the NTP will use medications like methadone, buprenorphine, and these medications actually help to reduce or eliminate the physical withdrawal symptoms by blocking the effects of opioids. And that helps to normalize brain structure and function. And the medications are a key component for treatment in an NTP and are often used, like I said, with their combination of therapies and counseling. The counselor in the NTP really manages all of the services that the patient's going to receive. They're kind of the quarterback of treatment for the multidisciplinary team, working to engage the patient and access important services. Maybe it's housing, maybe it's sober living, maybe they have educational needs, maybe they need some assistance in reunifying with their family. And really the counselor, works with the physician when the medication may need to be adjusted. And so it really is a good way to keep the patient on track. In counseling, I can't overstate the importance of counseling because it really helps individuals understand their underlying reasons behind their drug use. And it helps them develop coping mechanisms to manage triggers, to change their negative attitudes and behaviors related to their drug use, and really to build healthier life skills. And hopefully, the goal is always to support them into maintaining long-term abstinence from opioids. And so, there's a lot more services that the NTP does in terms of, testing for co-occurring, diseases that may result from their opioid use disorder, like hepatitis or HIV, and really kind of help link them for their physical health issues that may be detected by the OTP physician. And I really just can't say, enough about our programs. We're actually undergoing a huge change. NTPs are, require accreditation through SAMHSA. They're registered with the Drug Enforcement Agency, and they're licensed and certified by the state for Medi-Cal, and then they contract with the counties to provide services through the Specialty Behavioral Health Plan. And so there's a lot of people that look in and are involved into running and operating an NTP, but the federal government just released their first set of regulations modernizing the program in 20 years, almost a year ago, and we're working very closely with the state to help ensure that those regulations are implemented in California. They're really going to make some groundbreaking changes that are going to help improve access to our services. For example, they're going to allow for the use of telehealth for patient inductions. They're changing the dosing milligrams that are allowed. They've raised the cap, which is just so important as we see the increased misuse of fentanyl. They have the more higher dose of an opioid that somebody uses or misuses that impacts the level of or number of milligrams of methadone that they need to receive. So when you see people coming in with fentanyl, the 30 milligram limit at the state has been too low. And the feds have raised that to 50. So that's a 20 milligram difference. That kind of shows, or, to me, points out how strong fentanyl really is. They're allowing patients to take home medications immediately upon start of treatment. So methadone, when misused, can be fatal. And so there have been restrictions on when patients were allowed to start receiving doses that they can self-administer at home. And there still is a checklist of criteria that the physician needs to evaluate, but the federal rules do loosen up. And so we'll see fewer patients coming in today than normally do on a daily basis. Currently, about 25% of NTP patients in the state, which is about 40,000, go to the program on a daily basis. And we're also seeing an extension in what services, what we call physician extenders can do. So that would be a nurse practitioner or physician assistant. And so we'll see greater utilization of those types of licensed staff. And so that will expand the number of patients that can actually be seen in an NTP, which we're very excited about that as well. And then they're also allowing for medication units or mobile units, which is an NTP van, to provide the full array of NTP services. So for historically, if a mobile unit was delivering medication, the patient would have to come into the NTP for their counseling services. And so by allowing the mobile and medication units, which are, extension arms of the primary NTP to provide the full array of services, we're really going to see, remove some of those barriers and make it easier for people to access their counseling and other NTP related services. And so we're very excited about that as well. I know I've given you a lot of information very quickly, and I'm happy to answer any questions that you may have.
Great, thank you so much, Jennifer. I already see some hands here in the room, and let's see if we have some online. Let's go ahead with. Let's make sure to use the microphone.
Okay, I'm sorry. Thank you so much. This was a lot of information that makes me realize how important it is that the mental health commissions like mine really become educated in this. And even my clinical license doesn't require this as a continuing education at this time, which is something that it should. But anyway, there were two instances where you used initials. And someone just told me what NTP stands for, but there was another one that I thought had an M in it, and I thought that might be medication assisted, but it wasn't MAT, it was MAP, I thought. So.
I'm so sorry. So NTP is a narcotic treatment program. At the federal level, like in SAMHSA and in regulations, they're called opioid treatment programs, which is OTP. So sometimes those are used interchangeably. And I might have said MDT, which would be multidisciplinary team.
Okay, thank you.
And then there's MAT, which is medication assisted treatment or medication for addiction treatment. That seems, the MAT seems to be having different meaning now, but really, from our perspective, it's really the medication and the therapeutic services kind of overlapping, and that would be the medication assisting that therapeutic service. So
thank you so much.
You're welcome.
Hi, Robin Sales, San Diego County Rehab. My question has to do with methadone. I believe you named a bill that either was a federal bill or a state bill, and I can't remember what you said about changing how methadone can be provided, like you said telehealth, I believe you said.
Yeah, so SAMHSA issues the regulations for opioid treatment programs nationally, and they issued new regulations in February of 2024, and all the states are attempting to implement those now. And DHCS, the Department of Healthcare Services, is working on released a draft behavioral health information notice, and I think in November. And we're waiting, and we submitted comments. We're waiting for that to be finalized. But one thing that the federal regulations now allow for is the use of telehealth for patient intake. So if a patient is going to receive buprenorphine, that can be a telephone evaluation. And if they're receiving methadone, they're required to be present with another provider, and not necessarily somebody in the NTP or the narcotic treatment program. And so that's helpful because somebody may be interested in starting their treatment, but for whatever reason, they're not able to get to the program that day. And so we're excited to see that moving forward. Does that answer your question?
Yeah, and I guess the question is, my understanding of methadone is it's the acquisition of it is fairly punitive. Like, how does a person keep a job and have to go to a clinic or wherever to get the methadone? It's really hard to have a normal life if you're drug seeking a different way, which basically what it is. I mean, you're going for maintenance.
So currently only about 25% of NTP patients attend the program daily. And that is another change that the federal regulations made, which is it allows a patient to be eligible to receive take-home medication on their first day of treatment. So they have to check, do they have storage and safety, or their children present? There's like a checklist that the physician will go through when they make that determination. But because it can be a burden, but also, the average medication wait time in an NTP is about 4 minutes. We did a survey last year to figure out, what does it look like, and when you go to the program, and 4-minute wait time in any healthcare setting, I think is pretty good. I think we all go and wait 10, 15, 20, 30 minutes. Even in line in a regular commercial pharmacy, we can be there for a little bit. So again, only 25% of the patients attend daily, and for those when they do come in to pick up their medication or receive their daily dose, the average wait time is 4 minutes.
All right. Hi, my name is Cliff Caffey. And first of all, I want to say thank you for the information that you have provided us. It was great information. My question, let me put a disclaimer on my question because it might be just too large to tackle in a session like this. But my question to you is, what do you think that we can do to prevent the use of fentanyl?
That is, that's a very tough question. And I think, LaShawn spoke about it, so eloquently before me. I think that, the misuse of fentanyl, or even the synthetic fentanyl that's out there, is just so dangerous. I mean, I'm, a mom. I have, 5 kids. One's 17 years old. She's a junior in high school. And I shudder to think about what she could potentially have access to, at school, right? And it's terrifying. And so I think the real conversations with kids about the risks and what it means when you take a drink or take, something to smoke that's somebody else, that it could be laced with fentanyl. I mean, I think really speaking to children in their language and telling the truth is important. I too grew up with the DARE campaign, right, which was scary. But I think LaShawn, if she's still on, she has a lot of information on the prevention of the misuse. I know it's more than just say no, but I do think, real education about the impact and the risk of death is important to note. LaShawn, is there anything you want to add to that if you're still on?
I guess maybe
Right.
he's not with us.
So who do you think should be having that conversation with those kids?
I think it's their parents. I think it's the school. I think it's social media. I think it's, Instagram and Snapchat. I mean, I think anywhere that kids get information, they need to be informed. But I am by no means an expert on that type of campaign. But I don't think it's one person's responsibility to make sure that a child's aware. But I do think it's, at their dentist office, it's at their doctor's office, it's at their school, it's from their parents, it's social media, it's everywhere.
Okay, we have a couple more questions in the room. Go ahead.
Thank you. Jennifer, thank you again. California opiate maintenance, when I read that, I'm like, okay, we're a society that is tackling things at all fronts. And the question that was asked previously, how do we get this? It's our policymakers too. It is, the way that we're looking at substance use in our society is important because it's not just the kids. It is everybody that needs to be having these conversations openly and being outraged until the point to where we shouldn't have to not only tell them about the risk factors, because as you know, you mentioned DARE, just say no wasn't as effective, but the reality is to show them that these things are out there and we're losing lives. And I think that has to happen at younger ages. So I want to thank you for, highlighting what can possibly be done as a parent. We're both parents and, he knows my concern is always about all of the kids that are being exposed and the contradictions that they tell us that they hear adults say is that you're telling us what not to do, but everything around us promotes it being done in our society. And we have access to all that information now because 24/7, it's right here on our phone that adults created. So for some communities, I can tell you from
We can't
as a
have a
parent advocate
discussion
is not
without
enough.
a microphone in the room.
Right, I don't know. Yeah.
I think that the widespread distribution of Narcan is huge. I mean, I have it in my car, all my kids have it, whether they want it or not, because I tell them, well, you don't know when you might have somebody who needs it. I had a hard time getting the Santa Monica Fire Department and Police Department to even know what I was talking about in the beginning, when Steve was, proselytizing. And now we need to tell them as well that you might need 5 of these, to revive somebody.
Hi, I'm Steve McNally with Orange County, and thank you for your the information. I think it's hard for us because we've been so focused on MHSA, which is the BHSA, that a lot of our boards haven't seen the ODS Medi-Cal funding, and where so if you could maybe share with Teresa links to appropriate websites, and also if there's open data portal has a lot of data that might be available on the program performance. I happen to know the NTP providers in my county, but it's not because it's a topic that's talked about a lot. It's just something that came across my purview once. So I think if that's something you could do, that'd be helpful. And also on the discussion for parents, there are so many, SAMHSA has so much stuff to prepare parents to have the conversation. And, denial works until it doesn't work, even if the kid next door died. It's not going to happen to me. And the thing that what scares me is because they cut back on the Oxy and they cut back on, there's been an Adderall issue as far as supply. Kids who don't normally use stuff a lot might get it. And when you read about 7th and 8th graders dying, it's usually because they got Xanax or something over the internet. And so getting parents to get the confidence to have the conversation is really important.
Thank you, Steve. And that was a great plug for SAMHSA. They do have a ton of tools and information and toolkits on how to have conversations. And someone who follows SAMHSA regulations, I can't believe that I just didn't think to say that. So thank you for that. And I will try to find some good, helpful information or links to share with Teresa about ODS, about the organized drug system. So yeah, I'll see what I can get to her.
Okay, thanks, Jen. And we have
So,
one more room and then one online. Go ahead, Barbara.
my name is Barbara Wilson and I'm from North LA County where we don't have any children that are not perfect. And we have really good drugs because they call Uber and they are delivered. So, you know, we have no problems. And we have a lot of religious, what's called faith-based schools and homeschooling and no problems. So my background is entirely mental health. And my experience is that within the addiction community, there has been this philosophical kind of opposition to anything that was medical, like doctors, nurses, social workers. Anybody with any training was like spit on them, you know. So now that we are having to merge with people that have this belief, and I have a license, I wonder, now that I'm learning about programs like MAT, for example, which literally saved one of my clients' lives, but the people in the County Department of Mental Health that were treating him did not know about that program. So I wonder if you foresee, and Stacy sort of alluded to it, any kind of cross-training that will sort of introduce the medical model people, professionals, to the addiction model thinking and vice versa, so that we don't have people with long-term sobriety, but who also might have bipolar, for example, driving into a plate glass window because their sponsor told them they can't take even a Tylenol or they've lost their sobriety. You know, so I think, I'm just wondering if there's some plan on an institutional level, a systemic level, to bring people together and let them find where do we have common ground.
Yeah, and I you know, I've been in health policy for more than 20 years now in Sacramento, and I'm also a part of the committee that's developing the education materials that are going to be used for the substance use disorder counselors, the 2473 education requirements. It's 80 hours, and I think there is a lack of understanding or a bias and a lot of different camps, right? You've got the medical folks, you've got the substance use disorder folks, you've got behavioral health folks, and then you made reference, I think, in sponsor to some of the community-based treatment programs, and it's hard for everybody to know everything, and I think it's always important to remember, or to kind of note that I don't know everything and I don't know what I don't know, but there is more inclusion in substance use disorder recognition for other behavioral health conditions and other health conditions, partially in part, I think, because substance use disorder counselors are certified, have very limited, specialized education, and they are taught how to screen for other behavioral health conditions and then refer them out as necessary when they identify a patient with a co-occurring condition. But I do think that there is a general lack of understanding of addiction, how it presents itself, and it can present itself with a patient in some behavioral health and medical, with some behavioral health and medical providers, but not 100% of them all the time, right? An emergency room doctor is probably going to know what addiction looks like more than, a primary care doctor, that mostly treats people for strep throat and a sports injury they got playing pickleball, right? And so There are education requirements that are, you know, your basic course that includes addiction medicine through their education. And there are requirements, at least on the BBS, the Board of Behavioral Science, licensed physicians for licensed clinical social workers, licensed marriage and family therapists, and licensed professional clinical counselors. They are required to take continuing education units in the area that they specialize. So somebody that specializes in an eating disorder would take continuing education courses on that perspective or on that topic. And somebody that was, you know, crossed over into addiction medicine, they would take continuing education units for that, because that was their specialty. So I think yes, there is the need for broader education amongst all provider types in the healthcare system, behavioral health and medical. But I think that that's a very heavy lift. But I think the more that stigma for substance use disorder and behavioral health conditions is minimized, the more open that care providers are going to be to learning about it. Because not only are individuals, from what I've learned in this role at COMP and working in behavioral health areas prior to this role, was that the providers that actually provide the care for substance use disorder are stigmatized within their own professions, just because of the stigma that goes along with having a substance use disorder, whether it's opioid or alcohol or something else, right? And so I really think that recognizing that substance use disorder and opioid use disorders, those are, it's a condition, right? It's not a result of, being immoral or just being a bad person, right? It's a behavioral health condition that needs to be treated. And sometimes it requires medication to assist with that. And sometimes it's just behavioral health treatment on its own, but it is a condition that requires treatment. And I do think you're absolutely right about care providers not knowing enough, but I also think that there isn't a real willingness to say, oh, I went to a great, lunch and learn about substance use disorder today amongst providers, right? Because of the stigma that's associated with it. And so, anything we can do to kind of normalize it as a condition to reduce that stigma, I think it's extremely helpful. One, in getting people to acknowledge that they have a problem that they need help with, and two, helping providers identify when their patients may have an issue. So I think that was a little soapboxy, but I hope it answers your question.
Thank you. And let's go to our last person, Gregory, online.
Thank you, Jennifer, and thank you, Cliff and Steve and Barbara and all other questioners, because I'm on a behavioral health board in Sonoma County, and my fear is that opioid settlement money, and in our county we're being told we're going to be getting somewhere between $50 and $100 million, is going to be poorly administered or implemented or utilized because we don't have enough soapbox activists like yourself to be able to elucidate what we could do in order to be able to make the impact that you're talking about. So I guess what I'm asking you is, are there, because the opioid settlements aren't spread out throughout the counties, they're episodic on who joined the lawsuit. So some of us are going to be flush with money and absent ideas, and others may have great ideas and no money. So what do you think we should do with this giant opportunity, given the impact is equally giant?
There's been a lot, the Department of Healthcare Services, I think really it, does a lot with the opioid settlement money. I'm not sure, I don't know what services are in your county and where your services are lacking. I would definitely make sure that you have, I believe you have narcotic treatment program in your county.
We've actually been gone from that whole, we fell out of the service delivery 10 years ago, and we're trying to make up for it now lately.
You may, yeah, I'm kind of geographically challenged in my brain on where Sonoma County is. I think you're around Napa, right? Napa, or is that,
Yeah,
you're
west
more
of
towards
Napa.
the coast?
Coastal, yes.
So, there could be, providers from Marin that may be able to come out to your area as a mobile or medication unit. You might want to see if you can supplement something like that going in. The problem with medication and mobile units is they typically have a lower patient census than the regular NTP. And so it's very hard to keep them to sustain their operability because 100 patients versus 25 patients, you do that difference in revenue is pretty significant when you're talking about the array of professionals that they need to, utilize. And that's why I think telehealth is really going to be important in extending access. So I would be looking, maybe you can do something similar to the mobile and medication unit grant funding that Department of Healthcare Services issued. There's probably about, I can't remember if it was 5 or 15, so we'll say money with no specific amount to fund mobile units throughout the state to kind of help reach the areas that are underserved in some of the more urban and rural counties. How that money is being used throughout California is even actually a little bit unknown for me. I can't find one website or one page or one report that says California got X amount of dollars and we spent it doing A, B, C, and D. But I would really look at I would recommend not putting all your money into one basket. I would work on education and outreach, and I would work on treatment and services at the same time and try to tackle the epidemic that way.
Thanks, Jennifer.
You're welcome.
Thank you so much, Jennifer. Appreciate you answering so many questions as well as your presentation. And just so you all know, I see Jennifer, with different statewide coalition type activity, and she's a strong advocate. So, the types of things that she presented, she's probably been part of getting some of the things in place that are in place and helping us as we move forward in informing the system. And I try to be that go between between all of you and other statewide advocates, so that we can have a voice also in Sacramento with some of the issues where we need more resources. So thank you so much, Jennifer. Appreciate it.
You're welcome. Have a good rest of your day and have a great weekend, everyone.
Sure. All right, so I have a few minutes. I'm going to just give you an overview of what is in our issue brief. Let me share my screen. Let's see if I can get to this. And this link is it's in the chat. It's also been emailed to you. It's on the materials page that you can get to it, or just on our website. If you go to issues, substance use disorder page, you can get to the issue brief. Well, I think I should probably zoom in on this a little bit. Let's see. All right, so what we did with this, it's a 3-page brief that we go into information on statistics, what we understand to be key components in a local continuum of care, evidence-based practices, and program examples. So I'm going to just go through each of these sections really briefly, just so you can go back to this. And there's a lot of other links and information on our website and elsewhere that we can direct you to. But this is just to understand some of the breadth of this topic. So substance use itself, when we're talking about substance use, we're talking about both substances such as opioids and stimulants, as well as alcohol And I'll start with some of the statistics on the left side of this issue brief. Just talk about the large number of people that do have substance use disorder. And it is startling, and it is an issue that we know that's hitting all of our communities throughout California and all ages as well. 10% of Americans over the age of 12 have alcohol use disorder. We wanted to call that out. You know, alcohol is a substance that actually has some treatment and even medically assisted treatment that is effective. So wanted to make sure people are aware of the high number of people that do have that issue. Children and youth, nearly a quarter by 11th grade are actively using alcohol and drugs. That's a large number. And those that are chronically using, like daily, that's affecting their brain development. So we need to really be aware of our children and youth. Cultural disparities, we know that that there are disparities based on culture, and we have some data on that from the Center for Disease Control, and want to make sure that the practices put in place address some of the cultural practices, but also understand that we need to increase services and increase or decrease disparities. Drug overdoses, we've had a lot of Californians die in the last year. Over 11,000 died from drug overdoses. Opioid overdoses, over 5,500 Californians died in 2020 due to opioid overdoses. And of that, over 3,000 or almost 4,000 died because of fentanyl overdose. And of that number, 968 young people under the age of 25 died from opioid-related overdose. That's 2021. And then stimulants, when we're talking about stimulants, we're talking about cocaine and methamphetamine, those types of drugs. We know that overdose deaths occur because of those drugs, and also notice that over 70% of the overdose deaths related to those cocaine, methamphetamine, and other stimulants also involve fentanyl. So that's being cut into the other drugs, and people don't know. And then the last item for statistics, treatment. Only 1 out of 10 people who need substance use disorder treatment are receiving it. So we know that there's a huge need to increase access. And then as we jump over to the next column on page 1, under key components, we go with access first. You know, first off, we need to have access at every door. And for people that aren't going to any door, we need them to know that there are services out there. So increasing the communication of services, making them accessible. So if somebody does actually show up and ask for services, that they are not walking away because they didn't receive the type of service that they needed. So increasing the capacity of the system to engage people when they do walk through the door. We mentioned assessments on here. We don't want people having to have assessments every time they receive a service. We want them to receive an assessment and then have a record that other professionals can share, so people don't have to continually repeat their story over and over again. And we also want to reduce the documentation requirements for staff. I won't go through that whole thing, but wanted to just, touch on how important access is. And then we have a different summary paper on the behavioral health continuum that talks about, the breadth of programs that are needed within our behavioral health continuum for both substance use and mental health, and then all the sectors that intersect. Culturally responsive offerings are important to meet the needs of diverse communities. That includes race, ethnicity, culture, LGBTQ+, and age. And then quality monitoring, performance outcome data. We are actually, California is in the midst, because of Proposition 1, we're in the midst of identifying what will be measured. So definitely we'll see some measurements that will be standardized around the state and that you'll start seeing as board and commission members in order to assess whether your performance is good related to the programs and how you can improve. Workforce education and training is a huge issue. We identified through a needs assessment in California that substance use providers and workforce was a huge part of the behavioral health workforce needs. So we have more information on that in our workforce education and training issue brief. Here on page 2, we have community defined evidence practices at the top. Those are practices that there is evidence that they work. There have been studies done. There are a number of provider organizations around the state that were part of Reducing Disparities program, and they've identified practices that are useful to certain community groups. And so want to just remind people, I think we've mentioned this before in our community engagement trainings and other trainings, but it's important to know that that these practices exist, and to acknowledge those also within a behavioral health agency. Evidence-based practice, and fund them too. Evidence-based practices, we have a list here of what are evidence-based practices. I think there are maybe 5 or 6 that we pulled out with some examples. Contingency management is a way of reducing substance use of stimulants like cocaine and methamphetamine. Those don't, you can't use the medically assisted treatment right now. There isn't another substitute that the brain will latch onto that can take people off of those. But there is something that's used. The contingency management is a way of providing incentives. So there's a different way of approaching your brain in terms of, the dopamine and the receptors that cause the brain to want a stimulant. So it'll direct them toward different behaviors because of those incentives. And there's, of course, counseling and other services provided through these programs. And just as an example, a gift card might be something that is an incentive. Full service partnerships. I'm hoping most of you all know. Some people are just getting onto new boards and commissions. So I'll just briefly explain. Full service partnerships are some of the core programs that behavioral health agencies provide, and they provide what they call the whatever it takes approach. So they're integrating housing and benefits needs and employment needs sometimes, and substance use and mental health needs all together. So a few examples are ACT, BACT. So ACT is assertive community treatment, and it's just another term that's used and incorporates what I think is federally recognized as a model for what here in California we call full service partnerships. And then FACT is for the forensic population. High fidelity wraparound is in some counties just called the Children's Full Service Partnerships, where it's specifically for children and their families. And then within the full service partnership programs, sometimes employment supports are incorporated within all of those services. And so I just provided a short, brief summary of what individual placement and support is, and that's related to employment. So it's a wraparound within that model itself to help people achieve employment and is known as an evidence-based practice. But right now, people that are in any type of employment program that have entered into like the public system for services, if they're not using IPS, they might get like a 10% rate of employment, competitive employment out of the program. But using IPS, they've shown it to be 40%. There's rapid job engagement and just a really robust wraparound program. And that is part of the requirement for some of the new Medi-Cal program. I think it's called Behavioral Health Connect. So the counties that would like to tap into the funding for that program, I think this will become a requirement as well, so that they're offering these services. And then the harm reduction approach is mentioned here as well, and how important it is to reduce the harmful impacts of stigma, mistreatment, discrimination, and harsh punishment of people who use drugs, and especially those within different ethnic, cultural, racial groups. At the top here, we have medication-assisted treatment, and that is something that is usually used with opioids. It could replace the craving for the opioid when people have medication-assisted treatment. They no longer need a drug dealer to get their drugs, or they no longer need to be using prescription drugs illegally because they have a doctor that's helping them, and they take a prescription for something that replaces that, and they're able to work, be with their family, live in community, and be okay with this. And usually this is also coupled with counseling. There is also medication-assisted treatment for alcohol. I personally have a family member that received that. They had, during the pandemic, such a huge amount of alcohol that they were taking, and tried to just stop, ended up in the hospital, and then in a treatment program for a month, and used the medication-assisted treatment in order to stop. They also needed that medical attention to reduce the alcohol use because their body was relying on it. Screening, brief intervention, and referral to treatment is it's something that is used in like primary care settings. It's a quick method of providing some counseling and referral for people. And so it's in a lot of different settings where it can be just incorporated into, the programs that are provided, or the screening and the referral that the different physicians or providers normally give certain groups. And then we also have the therapies, evidence-based therapies listed here that incorporate a lot of times both mental health and substance use. And so we have a listing of that. And then on our website, we have even more information and lots of definitions, so you can understand what all the different terms are related to behavioral health. And I'm sure that's going to grow. And also acronyms. And then the last page of our issue brief has program examples. So I will stop there.